This is Omar Chowdhury, Fellow in Neurointerventional Radiology and Neurosurgery at Stanford University Hospital, presenting an educational video on endovascular reconstruction of an enlarging traumatic pseudoaneurysm of the internal carotid artery. Um, this is a 23-year-old patient who was thrown off a bull during a rodeo episode, hit in the head and the neck, was unconscious for 2 days, and was found to have a left carotid, internal carotid artery pseudoaneurysm, which you can appreciate on this coronal view CT angiogram of the neck of this patient after this episode. The patient ultimately made a reasonable recovery and was closely followed for this dissection and pseudoaneurysm in his distal cervical internal carotid artery, the junction of the cervical and petrous segment. Um, the patient was placed on aspirin 325 milligrams and Plavix 75 milligrams. On a follow-up 1-year angiogram, the patient was noted to have an enlargement of his pseudoaneurysm of his left internal carotid artery, which enlarged in size from a centimeter to around 2 centimeters over the course of 1 year. And additionally, there was also thrombus inside the aneurysm. This was appreciated based on an MRI of the neck and brain that was completed. The MRI did not show any infarcts in the left hemisphere. However, on the MRI images based on this circle of villus reconstruction, you can see that there's an enlargement of the left cervical petrous IC, a pseudoaneurysm, and there's some phloevoids there indicating possibility of some thrombus inside the pseudoaneurysm lumen. Because of these findings of enlargement of the aneurysm with associated thrombus, even though the patient had been on dual antiplatelets, we offered treatment to this patient. The treatment options at that time included conservative, dual antiplatelets, and follow-up, and we knew clearly this had failed because the aneurysm had enlarged. The other option was to surgically reconstruct it. This was again a big challenge because the segment was a distal cervical petrous segment, which would be very hard to approach microsurgically for reconstruction. Therefore, that option was out of the window. Stent-assisted coiling was another option along with flow diversion, but the vessel diameter was measuring around 6.5 millimeters, and the currently available stents, even the pipeline flow diversion, the biggest size available is 5 millimeter and enlarges to 5.25 millimeters. Therefore, none of those options were going to work. The other option is to do a deconstructive strategy, which is a balloon test occlusion and vessel sacrifice, which is not a great option in this patient because he's a young patient and we did not want to go that route. So we decided to choose the use of a covered stent in reconstructing this vessel. The covered stents are primarily used in the peripheral world for vessels that are atherosclerotically involved, but in this case this worked out as a very useful option, and it's something that we have employed in situations such as carotid cavernous fistulae. These stents are completely covered. They result in immediate reconstruction of the vessel. In a scenario where there is a pseudoaneurysm with no true wall, such as in this scenario with an associated dissection, then covered stents are an excellent option for helping reconstruct the vessel immediately, rather than an interval thrombosis of the aneurysm, which you see in terms of other flow diverters that are available in the market. In terms of room setup for a case like this, in which the patient was going to receive a covered stent, we do the case in a biplane angiography suite. We use general anesthesia. The patient has an arterial line, has a Foley catheter. We use neurophysiologic monitoring, upper and lower extremity somatosensory evoked potentials, motor evoked potentials, and EEG. And the patient is positioned supine, and the head is strapped in a neutral position for this procedure. These are a couple of images from our cath angio suite. You can see the monitors and the anesthesia machine behind it. Different views demonstrating our biplane setup in our hybrid suite, where you can see it's a fairly large room which allows accommodation for anesthesia, for operative setup, and also for neuromonitoring. This is a view of the anesthesia machine again behind the monitors. We used a 6 French 80 centimeter shuttle sheath for this patient and a Berenstein angiographic catheter for the selections. We completed a detailed cerebral angiogram first to understand the circle of villus in this patient. And then we had magnified views of the left internal carotid artery aneurysmal segment. We completed a rotational 3D angiogram to make the measurements. A stent selection and sizing was done, followed by stent deployment, and then post-deployment angioplasty. We used this setup as a fairly standard setup for placement of the stents in our cases. And now the next run that you're going to see is a cerebral angiogram, which was done in this patient before the treatment. And you can see this aneurysmal dilatation at the distal cervical internal carotid artery at the junction with the petrous segment. And the remaining filling of the intracranial circulation is fairly normal. But the contrast stasis really demonstrates the thrombus in the aneurysm. And you can see on this 3D angiogram different views. You can see this irregularly shaped dissecting pseudoaneurysm with measurements taken here indicating what it looks like. We used a Viabahn covered stent for this procedure. It essentially is a PTFE stent. It's a heparin bonded surface and comes in various lengths. As you can see, we used a 6mm by 25mm stent. The stent is interesting because it has goes through a 6 French shuttle sheath, which is what we used in our case, and it has two ports inside the catheter that carries the stent. There is a wire lumen which is attached to a rotating hemostatic valve and a flush, and then there's a side port which is actually a deployment thread, which once you're ready to deploy the stent and it's in position, you essentially unscrew this area and pull a thread which essentially deploys the stent, and we will see some images that clarifies that. In terms of sizing, as mentioned, we used a 6mm by 25mm stent. The stent deployment steps are important. These stents require the use of an 18 thousandths or 14 thousandths wire to cross the aneurysmal segment. We line up the stent markers across the landing zone of the aneurysm, and once the catheter is stabilized over the wire in the landing zone, then the deployment string is from that side port that I showed you already is pulled, which allows the deployment of the stent. Once the stent is deployed, the edges of the stent actually are not completely open, and when they come in contact with the body fluids at the body temperature, it essentially allows it to open up completely. But still, to allow adequate apposition of the stent, we recommend angioplasty over the same 18 thousandths or 14 thousandths wire after removing the stent catheter. And if you're satisfied with the positioning of the stent, then you remove the wire, and if not, or if you're missing the aneurysmal segment, then a second stent placement may be required. These steps will be something that will be demonstrated in the subsequent videos and slides that are to follow. This live fluoro video demonstrates that the 18 thousandths wire is in the petrous cavernous segment of the left internal carotid artery, and you will see that the stent, which is constrained between these two markers, is being advanced over this wire across the aneurysmal segment. And once you stabilize it, then you would be in a position to deploy it. This unsubtracted fluoro also demonstrates the same thing, where you can see the stent has been stabilized between the two markers in the aneurysmal segment. It's a very stable construct, and it's held in place, and then once it's stabilized, then the thread is pulled, and if you look carefully, you will see that the stent is going to be slowly opening up now, and it's a very controlled deployment across the area, and you can see it's opening up now and across the whole length of those markers and coming proximally, and ultimately it's like completely open now. Another magnified view of the same deployment, kind of emphasizing the point that the markers have to be lined up in the area of the aneurysm, and once the thread is pulled, then it allows the stent to open up in the area where the deployment is required, and you will see the same opening of the stent. The angioplasty is then used. We can use any coronary balloon depending on the sizing of the vessel. We used a peripheral balloon here, a Sterling 6mm times 20mm, which was as you can see in this picture, used to angioplasty the proximal distal ends of the stent to allow excellent apposition of the stent. And this is the angiographic run after the placement of the stent, and you can see the vessel is very nicely reconstructed and the aneurysm is completely gone. There is no significant endo leak, and the aneurysm is well treated. The patient did very well post-operatively, was kept in the ICU for 24 hours, was discharged home the next day, neurologically intact. Important to keep these patients on aspirin and Plavix for at least 6 months. This again is an off-label use for a peripheral stent in this special situation, but in our experience we found it to be a very useful method for treating carotid cavernous fistulae, especially the direct ones, and these aneurysms. We thank Gore Medical for product images, and this brings me to the end of the talk.